Okay, so what I want to do is go over the assignment you turned in online. Um, and that's the week 2 assignment, the dermatology, respiratory, and cardiovascular. Okay. So what I want to do is just go through this. You have yours. Do you have it up? Why don't you bring it up since you turned it in online? Um, okay. So what I want to do first is the first couple of questions were more about understanding the physiology um, that happens in our respiratory system, and everything that was said here um, in terms of the definitions of and physiology associated with or pathology associated with bronchoconstriction, reactive airway disease, chronic obstructive pulmonary disease, chronic bronchitis, and emphysema. Um, those were um, those were correct. Okay. As for um, as for the bronchoconstriction, um, the you wrote down steroid or bronchodilator. Steroids are anti-inflammatory. They have almost nothing to do with bronchoconstriction. So what you have, the bronchodilator is what you would use in these cases. Let me go ahead and close the door since Dorothy's closed. And for reactive airway degrees or airway disease, we can use several different drugs. We can use corticosteroids. Reactive airway disease almost always have um, um, an inflammatory component. Bronchodilators and basically beta 2 agonists. So the management there. So what you had written down was bronchodilators. So that's fine. Bronchitis is an inflammatory disease, but we can treat it with corticosteroids. We can treat it with oxygen therapy. But I like your addition, quitting smoking. That someone with chronic bronchitis should never touch cigarettes in any or smoking in any form, because it just makes things worse. And emphysema, again, bronchodilators, steroids, and in extreme cases, we also do lung transplants. Lung transplants are a bit on the controversial side, because the average lung transplant for the first transplant lasts about 7 years. The second transplant will last about 2 on average. So lung transplant has to be something that's done out of sheer desperation. Nothing else will work. And there are some conditions that require that, but that's not. Those are rare, and usually are associated with many other complications. But we do have that. Going down to the case studies. Okay. Would you, in the first case study, we've got a patient is, pardon? Yeah, returning to clinic without, C/O is without a recurring cough, or complaining of, rather, that's a different one. Complaining of a lingering cough after being treated for 5 days with a Z-Pak. That's azithromycin. Patient was compliant and wants a new prescription to stop the cough. Further evaluation, you find the patient is a 2-pack a day smoker and complains of coughing and short of breath with exertion, but denies other signs or symptoms of previous illness. Blood pressure is 136/90. The pulse rate is high at 90. Lots of reasons for that. Respiration's 30. O2 is down to 92%, which is below what we really want to see. And temperature, normal. No known drug allergies. Lungs sound gunky, but chest x-ray shows no infiltrates. Would you continue to treat with the antibiotic? No, because there is really no evidence that the antibiotics are having any effect on the disease. So we need to look at something else. So based on the patient's history, what would you prescribe? You say a bronchodilator, that's fine. You suggest albuterol, that's fine. So that you did, yeah, that one is fine. Let's go to the next one. Patient at the clinic complaining of short of breath with exertion. No previous illness, no signs or symptoms current. Vital signs within normal limits. Lungs clear in all fields. Chest x-ray clear. Further discussion reveals that patient feels tight and wheezy during exercise, but that the symptoms resolve with rest. Okay. What would be a reasonable diagnosis? Well, asthma would be one. Probably exercise induced, because this patient only experiences it after exercise. So what if anything would you want to prescribe? Well, again, bronchodilators. There's no evidence of other needs at this point. So you did well on those 2 cases. Which of the cane drugs is used in throat lozenges? And that's benzocaine. You can do that either by looking up throat lozenges or going to the store, or maybe even look on your throat if you have some cough drops, or on your shelf. Which anti-infective drugs used for skin prep? Chlorhexidine. Possible allergic reaction, yes, but in infants, there's also the potential for seizures with chlorhexidine. Okay, so there's some interaction with the CNS on those. Why should hydrogen peroxide not be used at full strength to clean points? Well, clean wounds, because it kills fibroblasts. And of course, if you remember from your A&P class, first stage of wound healing is to lay down a fibroblast network. So yeah, so it rips healthy cells in the wound area. So peroxide should never be used full strength. if at all possible. Okay, 18 or 17 rather, how does tretinoin treat acne? Well, it causes rapid division. So yeah, stimulates normal maturation of cells in the epidermis. Why would anyone want to use a, there's a number 19. What is missing here? There's a number, yeah, there it is. You have number 19. You have things a little out of order here. Yeah, there is. Okay, I need to check and see if I have an older version of this as my key. So the number 18 is diflucan. That's the only one taken orally. Chlorhexidine, 19, Physahex. 20 is Novocaine, that's the injectable. And then 21 is that you have here. And I have two more questions, actually. That's kind of interesting. Yeah. We should take a look at that. At any rate, you did fine on that. I liked your thinking on the, the case studies. That should help you when you think about the case study for your LRA. Okay. So it can mean without and other, yeah, complaining of, yeah. C/O, C is often used to mean with. It comes from the Latin word cum, which means with. And so in other contexts, that's one of the reasons I don't care for a lot of these abbreviations, because we have too many things that have multiple meanings. Okay. But other than that, you did fine. I just want to take a quick look and see what's actually.
But the multiple choice were right.
Yeah, multiple choice were all correct. Okay. So we'll just leave it at that. I'm not quite sure what's going. Hello, Glennis. You made it. Okay. And we're still expecting Cheyenne. So what we did was we went over the assignment from last week. So I can talk to you about yours on the break, perhaps. Okay. So this week, we have a few things to discuss. We're going to talk about the nervous system, and we're going to talk about pain. You all know that the nervous system basically is the circuitry that controls our body. The central processor is the brain, and you know that there's the central nervous system, which is responsible for autonomic functions, as well as processing of signals and general control of the nervous system. And then there is the somatic system, which is the voluntary system. The autonomic system is not really under our control, or very limitedly under our control, no matter what, yogis in India might say about being able to deliberately slow their heartbeat to some almost undetectable level. Most of us have no control over these things. There are many functions in the body that have to operate automatically. And they have to because they're the basic functions that keep us alive. Things like the heartbeat. We talked about that last week when we talked about the cardiovascular system. The heart runs on automatic. It beats because it's supposed to. Without it, we die. So it's an automatic system. Other systems that are out of our general control, we have very limited ability to influence the way they express, would be our GI tract. We can, to some extent, influence the way it works, but it still works. Peristalsis is an automatic function. The function of kidneys happen automatically. The bladder fills, we can control using the somatic system. We can control to some extent. If everything's working normally, we can control when we empty the bladder. When we can't, it's called incontinence. But incontinence occurs as a function of failure of the somatic system to allow us to control when these functions occur. So the other things is that happen is our breathing is an automatic function. It's controlled. It has some control that we don't consciously exert. Can we stop breathing for a little while? Sure, we can. We can hold our breath and theoretically hold our breath until we pass out, at which point we start breathing again. So this is a system that we have limited control over, and some influence over short-term issues. But the autonomic system goes pretty much regularly. The peripheral system, however, is anything coming off the spinal cord. The brain, the CNS, as you know, is the brain and the spinal cord. The peripheral system comes off the spinal cord and is our voluntary system. And we have the ability to influence that. You're here. Okay, good. Okay, so we're going to be speaking today largely about the nervous system, but we have kind of an I'd like to go through the week briefly. Your drug class presentation is due Sunday night. We'll give it in class on Monday. Okay, so we have that. We have a little exercise in a system and the nervous system. We're going to have a little fun with that, and we're going to talk about zombies. Zombies are as portrayed in Hollywood, zombies are a myth. Over the years, there have been some interesting horror shows about zombies wandering around, and it always amazes me. These shambling creatures that can hardly make a noise or make a decision and can't move very fast seem to catch people who theoretically can run, which doesn't make any sense to me. However, they have stimulated some interest in what would lead to the symptoms that we see, the things that we see in these portrayals, the shambling, the appetite, the stupidity, other things. What do we see? And so so we're gonna talk a little about how that relates to the CNS and the various parts of the brain and how they work. You have a question here, an assignment here. Zombies, are they possible? And in reality, it's possible to induce a zombie-like state in another human being. So you're going to investigate that. You do some searching and talk about what the drug in the Caribbean, but it's not in the Caribbean is where whole out of the and what happened? What happened? Apparent death, which means being so that and they would die. And what would happen? They wouldn't be dead, and someone would the buried and keep them. And that has led to but it's a reality. So, what I want you to assignment is to take a look at the are they possible assignment. Bring it up now. A natural product that induces a state that very closely resembles what we perceive in zombie, I'll call it literature for lack of a better term, because it always struck me as kind of silly. What is it? Where does it come from? How does it work? How much is needed? How long? Antidote? How is it admitted or administered? So what I want you to do is you've got a couple of choices, and I may at the end of today's class get you guys started on it. If you would like, you can work together on this assignment and help each other with it. Everybody will write it up, and you'll make a presentation in class. And so as a presentation, I want you to work on something that is serious, but at the same time, serious can be entertaining. So be creative in how you do this. So we want to see a presentation. I want to see a presentation. And that will be next week. So you'll work on it this week. So you can collaborate online. You can, email back and forth, but I want to give you time in class together, both this class and Wednesday's class, to work together on this assignment. Okay? Does that work for everybody? All right. Pardon? Yeah, I'm not looking for APA, okay, necessarily. What I want is something that's well written, has an intro and a conclusion, and some material in the middle explaining the points. Okay. Also, though, it should have references. Okay. So what I would like, that's what I would like to see done with this particular assignment. All right. So you already have your LRA, so I'm not terribly worried about APA. What I'm interested in here is your information and how you present it. Okay. All right. So we'll that's that assignment for this week. Yeah. Well, you will make a presentation, but yeah, you'll turn it in as paper copy. If the presentation is different from your paper, yeah. If you decide to do a little skit, write it up as a skit with parts and that sort of thing. And I don't expect you to be playwrights, so I don't expect stage directions or any of that stuff. But if you do that, that's fine. But I don't want you to distract from the information. Okay. Also this week we have a quiz. It's called Quiz 2 because you had a week 2 assessment. So this is just really the second quiz. So any questions about that? So let's talk about the CNS. Pardon? We are looking at the lecture on the nervous system, the lecture on CNS pharmacology. Okay. So along the way here, we'll look at a few videos. So since we are not set up for video here in the lab, I'll just turn my computer around and we'll watch it as a group on my computer. So what I want to do is start off with this, but I also have handouts, including if you want to take notes, a copy of the right now Nate is functioning as the librarian. Oh, then you want to look for Cody Smith. He's the computer guy. Assuming he's in, he's either going to be around back in LC5, or you might ask Roberta at the front desk if he's coming in. So he might be out. I'm not sure where he hangs out, especially when there's classes in that room. Pardon?
I went to the doctor
Yeah.
and I have a hemorrhage.
Ah. That's that's helpful, isn't it? Well, how much ibuprofen did he suggest? Yeah. Well, as far as the non-prescription analgesics go, ibuprofen is marginally better than others, but only marginally. we'll talk about pain control later, but or later this week. But the problem with ibuprofen is that it damages kidneys. But if you are taking low doses, the evidence is real sparse on long-term low-dose use of ibuprofen. High dose, my sister, the younger of my two sisters, made a really silly decision early in life. She decided that she was going to have the same extensive, painful arthritis that my mother did. That's a silly decision to make because, of course, she did develop it. The other two of us in the family did not make such a silly decision and did not. But her doctor put her on high dose, 800 milligram dose, several times a day of ibuprofen. And now she has significant kidney damage. So, just be careful with that. She decided it was going to happen, and we can make things happen. We have it. The interaction between and we'll go right back into the central nervous system right with this, right? The central nervous system controls our body. We actually can exert some control over what our CNS does by making decisions. It's complicated. Mechanisms are not so easily understood, but we can decide we're going to get ill, and we will. And people, I've seen people decide that they were going to have cancer because, well, other people in my family have cancer. And maybe that influenced it or not, but almost invariably, if they've made that decision, it happens. And so while there's some people would argue with me strongly on this, but I've seen enough evidence and I've read enough about the topic that we have a lot of control. There is something called epigenetics. Have you heard that term? Epigenetics means, epi means beyond. So it's beyond genetics. We think of genetics as you got your DNA and you read the DNA and generate RNA. The RNA heads to the ribosome and generates a protein. Well, it's a lot more complicated than that. There are chemical modifications that are made that turn genes on and off. There are, and some of those are environmental, and these epigenetic changes now are being seen as heritable. So changes that we, due to our lifestyle, due to drugs we take, I'm talking about licit or illicit drugs, we can change the way our genes express, and that seems to be heritable as well. We used to think that DNA was fixed. That's all you could inherit. No. The way the system works is much more complex than that. And we're finding, as we learn more about epigenetics, we're finding that people can make decisions, which means lifestyle, which also probably has a lot to do with how they decide to lead their life. So they make lifestyle decisions based on that. My sister decided she was going to have arthritis, and so she did nothing to try to ameliorate that. I think she just drank more beer, which didn't help, by the way. And it just kept going, So, and other people that there's a lot of information. Some of it people will argue with, but there's a compelling um, um, amount of information in the medical literature about the control we can exert on our bodily systems by the way we think, by the way we make decisions, by the way our CNS works. We have a lot. We have lot of control that we never understood. Um, one of the early examples of this was looking at why people under stress have more heart attacks than people who are not stressed. And there's lots of ways. Some of the best information for many of these things comes from studies of twins, identical twins. Theoretically, identical twins have identical genomes. And therefore, those genomes, in the old way of thinking, those genomes should express equally and the same way in both. And yet, anyone who has ever known identical twins knows that they're not identical. I mean, we have a number of friends who are genetically identical twins. They've been tested. And yet we can look at one. One of them will walk in the door and we'll know which one it is just by looking at them, because they behave differently, they walk differently. And it's not just that they cut their hair differently or anything else. If they had the same hair, the same clothing and everything, we could still tell. And it has to do with the way they live their lives. So what happens with this is we find out that stress induces a hormone, cortisol. And cortisol gets into the nucleus and activates genes that lead to, that cause heart problems. That's an epigenetic change. And that stress level is enough to really see that. And that has led us to understand that there are many other kinds of things that can go on. So we do have a certain level of control. Does it always work? Of course not. My sister may have thought to herself, well, I might very well have my mom's arthritis, and then done something to, if she had taken a course of action to ameliorate that, to have gotten better exercise, changed her diet, probably if she had cut back on the amount of alcohol she consumed, it would have helped as well. But if she had taken some action, it wouldn't have happened, or it might not have happened. I mean, some parts are genetic. I mean, there are 3 of us in the family, and she's the only one who has any of the symptomology that our mother had. So why is that? I mean, other than the wonderful diversity with which our genetics express themselves, which leads to the diversity in our species. Why is it that one person in a family will get a disease that appears to have a heritable tracing? It appears to cluster in families. Why is it that one person gets sick and the other one doesn't? A lot of it has to do with how the genes express, and we can control that expression with a variety of things. Almost any stress on our system has the potential for inducing the expression of different genes. Or as my naturopath likes to say, genes don't have to express just because they're there. And in fact, they don't. We all carry, a lot of different genes. And some of them are problem genes and some of them are not. And it just depends on the individual. But it all has to do with that. Okay, let's see. We are 10 minutes late on a break. Let's take a break. Okay. Okay. Let's get started again. First off, it's 2-minute meeting. In each case, I'm not recommending that you go to any tutoring. I need your initials on the second position here. All of you are doing fine. You're staying up with the work, which is critical.
Why did I sign yours last time and you signed mine last time? Or wait, yeah,
That's what happened, isn't it?
yeah.
Huh.
We'll just cross it.
Yeah, just cross it.
Okay. I'm like, no, my name is right there.
Yeah. Thank you. That's it. Okay, so Cheyenne had a question during the break about the Framingham study. Do you all have it done? That document? Then please do. I'd like to. All right.
Yeah, there's no chance to turn it.
But that's fine. Pardon?
I just got confused by that one.
Yeah. So you have a score for the individual you're talking about that comes out of each of those groups. So just one score for each. And that gives you the combined risk. Remember, it's only a risk assessment. It doesn't mean X is going to happen. It just means that it has a higher, from a statistical viewpoint. If you take a large sample of people, then that group, that cohort with that score will have a higher probability of cardiovascular. And that's all. It doesn't mean they will. Obviously, a number of people, even with high score, will have nothing going on. And it just depends on the individual. Let's look at the cholesterol. Look at those cholesterol. As we evolve our understanding of cholesterol, we realize people can have extremely high cholesterol and never ever have any, because that's the generally speaking, if people have cholesterol is a high drug. So we have, we have that component. That doesn't mean something. You're at a greater risk. If you know that, then take a look at lifestyle. Lifestyle changes, sleep habits, address is sleep. We know that in many cases, that seems logical to me. But in functional medicine, there are more sleep, getting 7 to 8 hours a night. Okay, I know that's hard, especially for students. We need more sleep. diet changes, meditation helps, okay? And of all of those, the biggest factor is the sleep component. It outweighs all the others, which doesn't say that you can have a lousy diet and smoke and have all sorts of fun as long as you get plenty of sleep. It doesn't say that at all, but it does say that that's probably one of the major components. Because much of our disease, much of our problems come from the body being sleep. Sleep has a very important function. Two things happen when you sleep. One, of course, if you slow down your body chemically, but another one is in terms of our brain, sleep is a time when we are actually integrating all of the things that we've got during the day. There's an old saying that people use in various which is that you learn in the rest. And that is to say that if you spend your entire life studying, which I hope you do spend your entire life studying, but if you take a break, you have to stop. Even if it's silly, like even if it's something like get away from whatever it is you're studying, because your brain actually is visually trying away and integrating. Physically, the same thing. If you are trying to learn a new physical skill, as perhaps a kind of trivial thing, you decide you want to learn how to. Okay. That's a physical skill, and it takes practice, and it takes failure to be also learn to fail. But one of the rules is that let your body learn from previous activity when it's not doing it. That's when we learn. So rest is critical from that standpoint. All right. As we know, the human nervous system is both central and peripheral. Central meaning the brain and the spinal cord, and peripheral is everything else. And in the peripheral system, we have, as well as the somatic system, the voluntary control system, we have the autonomic system. And remember that the autonomic system is divided into sympathetic and parasympathetic. And these two systems actually do different things. For instance, the sympathetic system causes bronchoconstriction, okay, whereas the parasympathetic causes bronchodilation. And the autonomic system is controlled and mediated by hormones. Hormones, we think of hormones as things like testosterone, androgen, estrogen, etc. But a hormone is really a molecule that controls a body system. So insulin is a hormone, for instance. So it's any chemical, can be a protein, it can be a steroid, it can be a long chain fatty acid like molecule, but they control functions, bodily functions. So obviously they are intimately related to each other. Clearly, even though we talk about the autonomic nervous system, it comes out of the overall control resides in the central nervous system. Okay, so the parasympathetic system in the autonomic system, the main neurotransmitter is acetylcholine. Acetylcholine is a molecule that is ubiquitous within the body. It causes what we call a cholinergic response, so acetylcholine. The parasympathetic system is what is poisoned by nerve gases. You may have heard of this poisoning in England of a Russian living there with a nerve gas. And the way a nerve gas works is that it inhibits the process of generating acetylcholine from acetylcholine esterase. Okay. So we use these and our rescue agents inhibit that particular function. So the parasympathetic system is responsible for smooth muscle constriction and responsible for the wave of peristalsis that moves food through our digestive system. The sympathetic system is responsible for the fight or flight syndrome, meaning it really keys us up. It increases blood flow, providing oxygen to tissues to provide energy for rapid action. It is the neurotransmitters here are epinephrine and norepinephrine. These certain epinephrine receptors in the body are more responsive to norepi, which is why we have both. And adrenaline. Okay, so this causes an adrenergic response as opposed to a cholinergic response, and increases heart rate, blood pressure, etc., and increases blood flow. Okay, by smooth muscle relaxation. The two systems really are controlled through a couple of things. The parasympathetic system is under the general control of the vagus nerve. The vagus nerve comes off the brain stem and controls of the various functions that are needed to run the body. The parasympathetic system affects heartbeat. It affects lung function, gastric function, liver, and contracts the bladder. So all of this works under control of the vagus nerve. The sympathetic side is controlled by the sympathetic ganglia that come off the spinal column. Now, there are sympathetic ganglia and somatic ganglia that come off the spinal column. So we have a number of these, and again, these control various functions, including changing heart rate, bronchodilation. It also, when necessary, will inhibit peristalsis so that we're not continually pushing things through our colon. It controls the the release of glucose from glycogen. As you may remember from your A&P class, glycogen is a storage mechanism for sugar. Okay. And controls adrenal function. It also inhibits contraction of the bladder. In other words, these two balance each other. The sympathetic and parasympathetic are two sides of the coin of control. The one side is more about constriction and pushing things through, and the other side is more about relaxation. And that back and forth is why we're not peeing constantly, for instance, and why we only process food through our colon when there's something to process. So the various types of neurotransmitters that we have, include acetylcholine, which is a mediator of transmission of nerve impulses in both of the nervous system, both of the systems that we have. It is primarily parasympathetic, but it's involved in other areas of the CNS as well. Epi and norepi, and a related compound, serotonin, are what we call monoamines, which is a topic, which is a source of the fact that we can use what we call monoamine oxidase inhibitors for treating depression. The metabolism of monoamines is carried out through a process first of oxidation, and then destruction of the molecule, and the MAOIs, monoamine oxidase inhibitors, will prevent that process. Many of the drugs that we use for treating CNS diseases will have effects at the monoamine level, norepi, epi, and serotonin. Glutamate is a derivative of glutamic acid, which is an amino acid, and it's something that when we generate that, it stimulates the pleasure center. So it creates a feeling of happiness and desire for things. That's why a lot of people don't like to see glutamate, monosodium glutamate, or MSG, used in restaurants, because it induces people to be happy to eat more. And of course, eating more is not necessarily good for you. It's not a good idea. Gamma-aminobutyric acid, or GABA, is an inhibitory transmitter. It helps regulate other neurotransmitters, and works with the immune system to buffer out so that we don't get a buildup of too much of others. You've heard of dopamine. Dopamine is used throughout the brain as a neurotransmitter, and dopamine is really rampant in our nervous system. It's used throughout the brain, and between the brain stem and the nuclei of the basal system, the baseline system of running our body. All of these things are associated with mental disorders of one sort or another, which is why we have GABA inhibitors and GABA agonists. In other words, things that will either that are either GABA itself or something that generates GABA. Same with serotonin and dopamine, norepinephrine, etc., as well as acetylcholine. All of these things have been implicated in a variety of different CNS diseases. Okay. So if we look at that, one of the slides here has some pictures that you really can't see very well in the handout. But the neurotransmitters really are important. This stuff on slide number 12 here uses a color code. For instance, schizophrenia is associated. Now let's get away from us. Let's be aware that there's a difference between associated with and caused by, because all of these are complex diseases. But schizophrenia is associated with very high levels of dopamine, whereas anxiety is associated with very low levels of dopamine, and happiness with with high levels of serotonin. Okay, depression is associated with low levels of both serotonin and dopamine, which is why we have the selective serotonin reuptake inhibitors as a class of antidepressant use. Love is associated with high levels of serotonin, dopamine, and the hormone oxytocin. And then the flight or fight syndrome is associated with very high levels of norepi and epinephrine. So we associate these, and we will treat sometimes diseases by trying to modify these levels of neurotransmitters in the CNS. So what kinds of diseases do we actually deal with in the CNS? The list of diseases starts off with stroke. Yes, stroke is a CNS function, although we can also have, and strokes, by the way, can occur anywhere in the CNS, which means brain down through the spinal column. Depending on a stroke is a disruption of blood flow within the brain. We'll talk more about stroke in a minute. But we also have seizures or epilepsy. Epilepsy is a very specific kind of seizure disorder. Parkinson's, Alzheimer's, MS, and the whole issue of the variety of motor neuron diseases, multiple sclerosis, amyotrophic lateral sclerosis, which is Lou Gehrig's disease, which is what Stephen Hawking, who you may or may not have noticed in the news, died last week, lived with until he was 76, probably the oldest survivor of ALS known. Psychological diseases such as depression, anxiety, bipolar, psychosis, and the hyperactivity disorders. Stroke, pardon? That's not a question that I can answer. Low levels of these or high levels have certain effects. Depression often leads So in that respect, yeah, if you kill yourself, but depression per se is not likely to be fatal, other than actions you take as a result. It can be very destructive.
You can live with it.
Yeah,
But it'll make you not want to do things that you're doing.
exactly.
Which can
Depression,
lead to that.
yeah, which can
But
lead
you
to,
can live with it.
yeah, you can live with it. In fact, well, yeah, but it also is it also can be modified. So
Yeah.
there's it's a state of mind, the chemical composition and activity in the brain. And again, here's an example. There's again, we'll get to depression a little bit more, but depression doesn't kill, but it does lead you to that can wreck your life. Also, depression can lead you to other things, stress-related changes, and can cause heart disease. Okay, and then that maybe. I mean, we're starting to get further and further away from the CNS, and which came first. But what happens is depressed people withdraw, they overeat, they often will move into their own fantasy world. We have a friend I found out has been taking drugs for 5 years. I wondered why we hadn't seen him in a month. Out that all he could do was sit and stare at the computer all day because he was depressed, which is a shame. He was a very talented woodworker and a very smart guy. But he was doing nothing, and it was causing trouble at home. Fortunately, his wife and son were understanding and were able to deal with it. But I've watched depression destroy people's marriages, destroy their relationships with children, with their siblings, parents. It's just, it's pretty nasty. And in our society, we are, we are very much, we don't like to deal with CNS disease, depression, bipolar disease, all these things because there's stigma attached to them, which is really not helpful. But I'd also lead people to denial, to refusing to seek treatment, to refusing to support family members that need treatment. I know of families where things just got getting worse and worse, and one of the reasons was because, especially when it's a child who has this, the parents see it as a reflection on them, and they refuse to even consider treatment. So there's ego issues on that side, but also it's societal. My father's family is Irish, and the Irish, it's a very great negative to be associated with mental. And so they resist treatment, they resist seeking help, and they won't allow their family members to do it. Really, there you have another form of mental disease, as far as I'm concerned. And I've seen it in my family. My father was that way with one of my sisters, and I'm still having trouble dealing with his attitude about it because it led to my sister's ultimate death. So it was kind of tough. But stroke, also known as a CVA, a cerebrovascular accident. So there's two kinds of stroke. There is which is an occlusive stroke, also known as an atherosclerotic stroke. which comes from blocking an artery in the brain. It is related to, but not necessarily strictly caused by, atherosclerotic plaque in the arteries in the brain. Can also be it can also come from a blood clot, but it can be there. Another is that we have a hemorrhagic stroke, often causing an already weakened artery in the brain to rupture. These are the ones that are the really super nasty ones, especially depending on the vessel that does rupture. Often associated with chronic hypertension. It usually results in extreme debilitation with an occlusive stroke. Yes, go ahead. Yeah, with an occlusive stroke, usually what happens is the damage to the brain will be localized, and depending on where that damage is, will show you what functionality is actually lost. Strokes generally are diagnosable by looking at a patient and seeing that one side of their body has a problem and the other does not. They have strokes usually on the left side of the brain. We know that the left side of the brain controls the right side of the body and vice versa. So a left brain stroke often will leave the right side partially impaired or even fully impaired, depending on where it occurs. And a right side stroke will do the same thing to the left. We also can tell because it's like somebody draws a line right down the middle of your body, and you can see one side of a face slump. And they can't talk because they can't move both sides of their mouths. That's very difficult. And it can range anywhere from, they can still function, they can still communicate, to being very, very much unable. Hemorrhagic strokes, what happens is the blood from the vessel seeps into the brain tissue, and blood's actually not very nice to tissues when it's outside the blood vessels. And so it actually kills the brain tissue, besides the fact that it's not getting blood circulating properly to exchange oxygen for carbon dioxide. It actually gets in there and damages the tissues, and can lead to sometimes extensive damage and loss of functionality. They are the ones that are likely to kill the patient, as opposed to just make them impaired for life. So we have these kinds of things. What can we do about that? Well, if it's an occlusive stroke, we can give certain drugs like the thrombolytics that we talked about on Wednesday, Activase or streptokinase or one of those, to dissolve the clot and try to return some blood. What we're finding, we used to believe that the brain, once damaged, was damaged forever. And that's only partially true. Because the brain, recently there have been several books and a lot of publications, scientific publications, on what we're calling the plastic brain. Plastic basically means shape it, and the brain itself can repair itself. We used to think that your brain cells were fixed as soon as your brain stopped growing as a child. Well, not 100%. The brain does a couple of things. one thing is reroute the signaling pathways so that with proper training, and this is something my wife did when she was still working as a physical therapist. She could get her stroke patients to regain a lot of their functionality by simply teaching them how to use the body through its deficit. What happens is the brain reroutes all the signals, and you go from not being able to raise your arm up like this to being able to do this. Now, this isn't this, but it's a heck of a lot better than this. And so we can learn a lot about, we can retrain these with proper intensive therapy. And this is one of the problems in our medical system. We don't recognize the value of doing that. We won't pay for it. But if you can get someone who's willing to work with a patient, they can often regain a lot of their functionality. My wife worked one time with a patient with a head injury. Head injuries often mimic the damage of stroke. Besides, they cause problems. When David came to Susan, he could barely walk. And she worked with him for, I guess, on and off for a year. It was destroying his marriage. It was wrecking his life as a kid because he had a head injury while parasitic. And he became a very different person. His personality changed as well, which happened with head injuries. His personality changed extensively. And he had a very hard time maintaining the relationship with his wife and his kids. And his wife, bless her heart, she found out what Susan did and contacted her and started bringing him over. So we used to see him at the house a couple of times. My wife was working at that time. We used to see him a couple of times a week. After about a year, he was running, pushing the baby. And he was barely able to walk when we started working with him. And then after we moved out here, this is when we were living in North Carolina. So about 2 years after we moved out here, we got a phone call saying we're going to be in town. And he was now driving his motorcycle. Now he had a 3-wheel bike instead of a 2, but he was riding his motorcycle cross country. That's how he returned. That's because he was able to work, and he worked. I mean, he did work. You have to work. He was motivated, but he retrained his brain. So the brain can actually recover a lot of these functions. And so one of the things we don't want to give up on, and I really get annoyed when I hear a doctor, well, they've had a stroke, that's it, they're not going to ever get better. That is an absolute lie. They can get better. And as we understand more about the way the brain works and we understand the plastic brain, we begin to do that. Is that a
The goal is to be able to stand for 15 minutes after you sleep or laying down for a while. That's what they're doing.
That's part of it. That's retraining the brain. Again, as I said, you learn in the rests, and that's critical to this methodology that my wife uses, called the Feldenkrais method. It's critical in that you train and train, and then you say, okay, don't do this for a while, go to sleep, take a nap, whatever. And that's why this learning and the rest, because then the brain is busily, instead of doing, the brain is rerouting and learning. But you have to be motivated. You have to work at it. And there are plenty of people that are, especially if they think they have a chance of recovering most of their functionality. They'll work pretty hard. But they have to know that there's a chance. And that's one of the things that's missing at the moment. But yeah. Okay.
Even if I would still go as far as I could, as hard as I could.
Sure.
Maybe overdo it, but
Well, as long as you stop when you get to the point. You know, the issue here is when we're doing any of these things, we'll get to a point where we'll be doing well, and then we start getting tired, and then we start not doing well. And that's when you have to quit. And then take your rest. And then come back and you'll find that you can do more and more and more. But it's all about retraining. The body is amazingly trainable, including the CNS. It's amazingly trainable. Then there's the another one, we call it the transient ischemic attack, or TIA, also referred to as a mini stroke. These are little things where something happens and you have sort of mild stroke-like symptoms. You know, when, as I said, I think once before in this class, there was a time when I was around my father. We were around my father enough to notice that he was having TIAs. And the way we noted it was because instead of being able to walk normally and pick his feet up, he would pick up his, I want to say his left leg, and he couldn't hold his foot up. It was, we call it foot drop, where the toes go down and you have to sort of fling your leg out and make let physics lift it instead of muscles. Usually these symptoms go away. They would last for a little while, and then the next day he'd be fine. And then he'd have another. A lot of times people don't even know it. He never realized it. And we saw it. And we had a talk with my brother-in-law and sister who have been doing a lot to take care of him. And we told them, you know, this is what's going on. And you know, so they had a discussion with his doctor about it too. So really is critical. Again, what you don't want is for this to go on forever, because eventually it can go into a full-blown stroke.
so it's not like the blood clots.
Mm-hmm.
It's not completely blocked, or the artery is not completely
It
blocked.
is partially blocked. It's restricted blood flow. It's sort of like angina in the brain. And then the natural mechanism in the body for cleaning up clots take over and take care of it. It's usually going to be an embolus of some sort. The body will resolve. And again, you have to be watching sometimes to see it. I have seen people with TIAs go and you know, just see briefly, you'll see a slight slumping of one side of the face. And they'll have that for a while, and the next day they're fine. And so you think, did I really see that? And the answer is, if you're observant, you probably did. And it's something to ring some alarm bells.
Yeah, 'cause my dad was like, he had an infection. So I was, but I've never thought it was like a mini stroke before.
It might not have been. It could be something called palsy.
Mhm. That's what I was going to.
Yeah. Because and people will get that. We had one of my wife's cousins got the pneumonia shot, and 2 days later, just, and that lasted for several months. Usually it recovers completely. For her, it lasted several months, and we were very concerned. But that's what it was. It was Bell's palsy, and it was caused by the pneumonia vaccine in her case. But that does happen, and that's a vagus nerve thing. So, okay, let's. It's 20 till. Let's take our second break.
Yeah.
Class. So, treatments for stroke. There's not much you can do for a hemorrhagic stroke except supportive therapy. Occasionally, depending on where it is, you may be able to go in and do some surgical repair, but for the most part, hemorrhagic stroke is not much you can do. but for occlusive stroke, what you can do is use, as I said before, thrombolytics, clot busting drugs. You want to do this as quickly as possible. The guidelines are within 3 hours, but that really at 3 hours you're running into issues already. So you want, if right now the guidelines are if you can get, or the research shows that if you can treat people within about 20 minutes, they have a good chance of recovering a great deal of their deficit. But again, we have to treat, we have to sometimes re-educate the brain. Other things you can do is you can, if you are at risk, if you're a patient who's already been identified as a patient at risk of having an embolus, then we can treat with drugs that reduce the symptoms if it happens, and or can help prevent a stroke. Things like platelet inhibitors, aspirin, which is the prototypical platelet inhibitor, heparin, and anticoagulants, such as Coumadin. Won't go into much on Coumadin. Coumadin is probably the most prescribed anticoagulant, and it is one of the most prescribed drugs in the United States. It interferes with vitamin K dependent clotting factors, and so if you have an overdose, the treatment is lots of vitamin K. We can inject vitamin K, or we can have people have vitamin K some other way. We also tell people on warfarin they have to avoid certain foods like spinach or kale, that sort of thing that has very high vitamin K levels. So only problem is this is also, warfarin is also rat poison. And how does it poison the rats? Well, it makes their blood not clot, so they get a minor injury and they bleed to death. Maybe not a pleasant way to go, but I'm not sure too many people are that sympathetic to rats. Although I've met a couple of nice rats. Yeah. Yeah. Yeah, because they often cut themselves, and it's very hard to stop the bleeding. My mother-in-law loves to pick her nose. I don't know why. And as a result, she gets bloody noses because she's on warfarin. And the doctors call that digital trauma. And we've gotten her largely to quit doing that, but we've noticed that. Let's take a look at some other pathologies, seizures and epilepsy. Seizures are hyperactivity in the brain, and causes of many of these things are just not known. Many and most cases of seizures are unknown. Sometimes it's pretty obvious. They get a very high fever, so they have febrile seizures. Brain injury often will result in seizures, and it's really a disturbance in the electrical activity of the brain, much like the heart, where we can measure the rhythm of the heart with an ECG. We can look at the electrical activity in the brain through an EEG, an electroencephalogram. And normal brain activity has a defined pattern, and seizure activity also we can see seizure activity on these, and it involves a lot of excess firing. Epilepsy Seizures themselves can happen randomly. Epilepsy itself as a disease is permanent and recurring. Lots of different kinds of seizures. The ones that we look at and see depicted in movies are people having these fits and lying on the floor and they're trembling and their muscles are contracting and relaxing and stuff. We call those generalized tonic-clonic seizures. Partial seizures, where we don't see all of those symptoms, are the most common. We have absence seizures. Basically, the brain activity is going on and you can just see it in a person who has an absence seizure. All of a sudden, they're just not there. You can talk to them, you'll wave your hand in front of their face. They're just not there. The brain activity, is whatever's going on in there, has interfered with their ability to interact with the world. Status epilepticus is an emergency condition and needs to be dealt with. It often results from brain injury, or if it's a really major chemical event, can cause brain injury or even death.
How do we take care of people with stroke as they're having stroke?
Having strokes
And
and seizures. With seizures, what you want to do, it used to be that we were worried about silly things like swallowing tones, which people cannot do. What you want to do is make sure that there's nothing in their mouths that they can suck into their windpipe. But the other is make them comfortable. Clear obstacles. I've had 2 seizures in classes that I was teaching down in Denver. One was a person who came in with his girlfriend so she could practice phlebotomy on him, and he had a seizure when she stuck him. So what we do is we try to keep them safe, get them to the floor if possible, so that they're not falling and hitting their heads. We would cover them. We would get blankets. I was right around the corner from our CNA lab, so we always had blankets and pillows in there, and we just run and get them, and clear the furniture out of the way and just basically make sure they were safe. Usually they'll have a seizure and then they'll recover, and often they'll have no memory of it whatsoever.
we let it pass.
Pardon?
We let them pass.
Yeah, that's basically all we can do. I mean, as first aid. No, you don't hold them down. Don't put anything that's going to make them work against you, because that can lead to muscle damage and further damage. The object is to cover them, keep them warm, and keep them safe.
Why do we keep them warm?
Pardon?
Why do we keep them warm?
For various reasons, that helps with blood flow. It also, when you're having a seizure, your brain thermostat goes nutsy as well. And so what we want to do is just keep them covered and safe. Biggest thing is get something under their head so that they're not banging their head. But, in both cases in my class, I just had the students clear all the tables around them. We set them on the floor and got them covered and immediately called 911.
How about a stroke?
Stroke. Best thing to do with the stroke is call 911 immediately. Get them to a hospital. If you can, you don't want to try and transport them, because then you have to move them. And if they're having real difficulties, that can be hard, especially if you're not exactly a huge person. If you were dealing with a 200-pound man, it would be difficult for you, especially if they were prone, if they were on the floor. So the best thing to do with a stroke, again, is get them comfortable and call 911. Get somebody to transport them to a hospital immediately. Again, with stroke, the key is fast action. Time is critical. In fact, the stroke protocol, they call FAST. You look at the face and see if it's slumped. You look at the arm and see if one arm is not working as well. The best way to do that is say, lift your arms, and the one that's not working either won't go up or will fade back down. And then get them comfortable and let's see, what's the rest of it? Speech. Can they talk? Can they repeat a sentence to you clearly? Because a lot of times, of course, when their face is that's another good diagnostic procedure. And then it's, if they show any of those, that's when you immediately call and get them to the hospital as quickly as possible. We need them there within a short period of time. The biggest problem with any of these things is making certain they get seen quickly by the medical profession. That's the killer.
I don't know if you can help me understand, but I wasn't home at the time, but my dog wasn't breathing. I wasn't there, but they're telling me that they said a seizure. She wasn't breathing. Her tongue was turning blue. And we had somebody come over not right away, but they were just coming home. And they said, get some oil, a spoon of oil, and put it in her mouth. Like make it go down her throat. Did that even help, or did the seizure just go on? I mean, just stop on its own?
It probably would stop on its own, but it might, you may not need the oil. You might just need to, like a spoon in their mouth. And it might be that stimulus was what they needed. Because I can't imagine putting a liquid into an animal or a human having a seizure. That's a good way to have them go, and then you got real problems. But not down their throat, isn't it? Just along, it's right in their buccal area. So what you're doing is giving them a buccal medicine, but you don't squirt a lot of material, right? Yeah. My biggest concern about putting anything that is there again, what you've got is you've got control over that amount of material, and so I part of it I think is the stimulation that changes the way the brain is perceiving its surroundings as well. But fortunately, I haven't had to deal with all of that. But I would think that that's what it would be, that sort of stimulation of the system.
Mm-hmm. Yeah, but I don't understand this. Why was her tongue turning blue?
She wasn't breathing.
Oh, yeah.
Yeah, that would be. And somehow or another, it turns blue because blood circulation isn't getting there. There could have been something else going on, and dog physiology is a little different than human, so hard to know.
Yeah, I still have it. It's been okay. I'm glad it wasn't there to see it.
That's scary.
I wouldn't want to.
Yeah, it was. I'll tell you. I have to admit that I was glad that I was fairly well in control when my students were having seizures in the lab. Yeah, I was lucky the second time. One of my students had one of her kids was an epileptic, and she knew exactly. I was grateful, believe me. And I learned a lot from her right there. So, but she was very, very good about it. And, yeah. Yeah, that's another thing. These drugs can cause seizures too, especially this. How old?
Um, 7 months old. So what would she do then? Like she watches them because she already took the doctor. You know how far they are and for how long and stuff like that.
Uh-huh. What they're trying to do is diagnose potentially if there's some sort of disorder that can be treated. Seizures are very difficult. They're, again, treating seizures is is an interesting approach because you don't really there's no guarantee of any success. I had another student who was an epileptic, and none of the drugs worked on her. So she had a seizure dog, companion animal, that would tell her when she was about to have a seizure. So obviously something is going on, and the dog could smell whatever she put out. Yeah, yeah. There's great stories about cats about that. Yeah, yeah. But yeah, and so what happened is her dog went with her everywhere. Sat in class with her. is the only animal we allowed on campus. But when the dog would let her know, and she would lie down if she was going to have a seizure. He would nudge her. It was they trained them to have a specific signal that says lie down, you know, and so she would. But we have a lot of different kinds of anti-seizure drugs. One of them is one of the oldest is phenytoin, also known as Dilantin, which has been used for years, and is you know, pretty effective. It's still being used. Some of the benzodiazepines, the Valium family, Librium, and so forth, some of these are used as well. They're mostly anti-anxiety agents, but again, seizure disorders span a full spectrum, and a lot of times we just have to experiment with the patients. Some of the barbiturates, like phenobarb, which may be with your friend, may be what they decide to use because that's usually first choice for children. But they need to know some idea of the types of seizures and the duration. Some seizures are short. I have seen absence seizures, and they'll last sometimes 5 to 10 seconds, and other times they'll go on much longer. So they need to know a lot about that. And then a number of other drugs have been developed, and they don't. It's difficult to see all the time what to treat with, and a lot of times they just have to try. I'm going to pass another set of handouts here.
So seizures aren't dangerous, but they are something else.
Seizures are dangerous.
But they're an indication.
They can be. Seizures are symptomatic of something going on in the brain, and the problem is it's very mysterious. But the damage, one of the reasons that if you have a seizure disorder, you can't have a driver's license. And you have to be, some states, I think you have to be 6 months out from your last seizure before you can apply for a driver's license. And in other states, it's a year. I think in Colorado, it's a year. You know, theoretically, since you have all this electrical activity going on, it can. But again, it's all situation and individual dependent. People who have seizures appear to have normal intelligence. They appear to have normal, non-seizure related body activity, So that's, brain damage. I mean, who knows? Well, if you do hit your head and cause a seizure that way, that is from brain damage, and that's causing some sort of electrical malfunction, actually chemical. But anyway, I passed out something that you'll see several of here. This is the pharmacology of the gamma aminobutyric acid synapse. You have pain management. How'd that happen? Okay. Yeah. Let's see. Yep. I had that. All right. How'd that get there? Okay, thank you. You'll get that. You'll get the pain management soon. But anyway, there are several here. The pharmacology of the cholinergic synapse, the GABA synapse, noradrenergic, etc., and serotoninergic. This will help you in many ways understand why we choose certain drugs for treatments. But if we look at what happens here, some of the drugs will inhibit some breakdown products of GABA and some metabolites of GABA, and others will inhibit the release of GABA, and the Valium and others are functioning at the benzodiazepine receptors, which then make the GABA receptors more sensitive to these drugs. So that the whole the treatment is dependent on what the doctors determine. A lot of times they just go from drug to drug to see if it's going to work, to see what will work. The oldest of our drugs is Dilantin, phenytoin. It has a lot of side effects, but it is effective in certain kinds of seizures. The use of the benzodiazepines, Valium, Ativan, a lot of times what happens is a person who has seizures regularly also can sense them coming on. There's something called an aura that they can, and what this is a visual issue for them, that they can feel and see that this is about to occur. Yeah, we call that a prodromal symptom, a sign. Yeah, so you do something about it. Well, if you know you're about to have a seizure, you can often short circuit it, so to speak, with Valium taken sublingually. It works very, very quickly. But it is, pardon? Under your tongue, yeah. Under your tongue. Or there's a rectal form as well, a suppository form as well. Many of the others have been around. One of the most recent drugs is a drug called Keppra. It's sort of a drug of last resort because the side effects are really, really bad. On top of that, it's hideously expensive, I'm told. But it's a drug that's been on the market now for about 5 years, I think, and is still considered a about a last resort drug if nothing else works. Often they will be used in combination because people have seizures from a variety of different sources. It's a difficult thing to treat. It really does it really does require a neurologist who's experienced in seizure disorders to treat. And so if you have a seizure disorder that you're dealing with in yourself or a family member, make sure that you are seeing a neurologist, because they're the only ones that really have the experience with these. There are lots and lots of slides about drugs. Well, we won't go through right now in any detail. Parkinson's disease, characterized by tremors, difficulty of coordination, a shuffling gait. This is looks like and it really results from decreased dopamine levels. And so we use dopamine mimetics to treat them, carbidopa, levodopa, and so forth, to treat this. The drug has exacerbations and remissions. And so it's pretty nasty physical disease, and is characterized by some changes in parts of the brain. There are no cures. There are only treatments that can lessen the symptomology. When you see someone with these tremors, now that doesn't mean that anybody that has a slight tremor has Parkinson's, but it's when it's when it is constant. We all go through times when we're tired or whatever, and we have a little tremor. But this is, and also there's a postural issue. They sort of stoop and lean over. Now in this society, an awful lot of people do that. Why? Because we sit here at our computers like this. But this is as people are walking down the street. I look at a number of my neighbors who are elderly, and wonder about some of them just from their posture as they're out walking, and wonder if they have Parkinson's. Treatments are number of drugs. So you can look at them and wonder. That's not a definitive. As I say, an awful lot of people are doing this, and also older people without Parkinson's will tend to slump a little bit. Yeah, well, and if her posture when sitting and watching TV is like this, then it's going to be that way when she stands up. Yeah, well, that's because she's put herself in that position. The best thing she can do, to give you a little hint, those the little swimming pool noodles that they sell for kids. Take one and cut about a 3-foot piece off of it, and put it behind her in a chair and have her sit against it with her entire back, and that'll help. Another thing is if you don't, is make sure that when people are seated, encourage them to sit back in their chairs, lean back against the back of the chair. And part of that, if you look at somebody who's slumped like this, what are they doing? They're compressing their lungs, they're compressing their heart, they're compressing their internal organs. Mm-hmm. Might. What is, how old is she? Okay, that's a little young for that. But does she drink a lot of water? Yeah. Okay. Yeah, well, we won't go there. So yeah, there's a lot of reasons that could happen. But one of the things, as I say, a little simple pool roller. Go to Target or Kmart and spend $5 or whatever and cut it into 3-foot sections, and have her put it behind her and sit against it. It's a very good tool. So what we want to do with Parkinson's is rebalance the dopamine and acetylcholine levels, and there are a number of drugs that can do that. Some of them are cholinergic drugs, some of them are dopaminergic drugs, and again, what we do is we have to see what works on the individual patient. The different side effects and different drugs are useful in different populations. Parkinson's can appear in all ages. We think of Parkinson's as something that only older people get, but it's not. Like anything else, a wide variety of people can have it. One of the most common drugs is levodopa, and it's almost always given in combination with another drug, carbidopa, and to enable us to reduce side effects of the levodopa by quite a bit. This drug called Sinemet has a lot of side effects. The problem with any of these drugs is that if there's a problem with the drug, if it's not working well, we don't just stop taking it. There's a rebound effect. The disease can get much worse. The issue one of the issues with CNS drugs is they often will produce side effects that look like Parkinson's. And so what happens is that then they go from having, say, an antidepressant to being given an antidepressant plus anti-Parkinson's disease drugs, when it's not Parkinson's, it's the drug, the antidepressants, that's the cause. So if you're in a situation where you have someone especially close to you who is being treated for depression and they start developing symptoms of Parkinson's disease, talk to the doctor about getting a new antidepressant drug, because it may very well be caused by the drug. We have a number of drugs that are agonists. We call them dopamine agonists. They imitate dopamine. And of course, all of them have lots and lots of side effects. Alzheimer's disease is a progressive neurodegenerative order that gradually destroys memory, thinking, and language ability, and behavioral changes. Some Alzheimer's patients become violent, and some don't. but they lose the ability to to make good decisions, and they also lose their ability to remember who they are and who the other people around them are. It's a very frustrating disease. Lots of theories as to what causes it, but nothing proven. And the only real diagnosis, if someone says, well, he has Alzheimer's, there's no way to really know that until they autopsy them after death by examining the brain. Because they're looking at the signs and symptoms. Yeah, the problem is dementia is a catch-all term for people who aren't thinking right. Well, drugs can induce dementia. You can have a normal brain and have dementia-type changes in your thinking that are unrelated to Alzheimer or anything else. It is not a normal part of aging. In other words, there's no reason to think that any of the four of us in this room will ever develop the disease just because we get older. The problem is older people, who, for whatever reason, begin to lose memories and lose some of their thought processes, are often just, oh, she has Alzheimer's or he has Alzheimer's. And there's no guarantee of that. As I say, the only truly definitive diagnosis is autopsy. So until that, what we do is we look at the whole symptom complex of the patient, the syndrome itself, and we make a judgment based on what we see as to what the disease is. There are lots of different kinds of dementias. Alzheimer's is one of them. There are, as I say, lots and lots of estimates as to the cause, but in reality, we don't know yet. When you don't know the cause, it's kind of hard to treat the disease, by the way. And the reason we can detect it at autopsy is we just physically examine the brain instead of the brain that an Alzheimer's patient brain is morphologically different. There are different gaps, and there are some sticky clumps of plaque that are seen on autopsy. And they're composed of a number of things. Treatments, well, right now there are some drugs that have been experimented with. There's a big move to have these so-called cerebral enhancers for treatment of Alzheimer's disease in the past. They have not been shown to be effective, particularly. But some of them will have some short-term benefit to patients to try and slow the progress of the disease. Lots and lots of stuff is going on. Lots of research in the field. But there's not, right now, even the best research is not producing more useful interventions of a drug type. We're learning better how to deal with behavioral management issues. And also, quite frankly, what you have to do is when you're dealing with especially a relative who develops one of these dementias, whether it's Alzheimer's or any other dementia, is you need to have a lot of patience and understanding, because they're not doing it on purpose, even though it might seem that way sometimes. So there are lots of different drugs that have been experimented with. MS and related disease is neurodegenerative diseases. If we look at a typical nerve cell, there's the cell itself, and then there's the axon that comes off the cell. It is surrounded by a fatty material known as myelin, and that protects the nerve from outside stimulus, and protects the from all of the other stuff that's in the body, chemicals and other structures. That myelin sheath is lost in things like MS and myasthenia gravis and Lou Gehrig's disease, and other related disease. So MS has no cures. We have drugs that we can use to reduce the likelihood of advancing the disease. But once you have these things, once you have one of these diseases, there are no cures. We can also treat some of the symptoms, the muscular spasms that patients have, and apparently they're very, very painful. And we can give drugs to reduce the spasms that they suffer from. Lou Gehrig's disease, or ALS, is very similar. And again, no treatments, no cures, although there's lots of research going on. Let's quickly talk about depression. Depression has lots of drugs to treat it. Depression is, again, a complex disease. It is one of the most common psychiatric disorders in the world. There's a whole line of signs and symptoms of the disease. Basically, loss of interest in life and everything around there. Insomnia is one that can be a problem, or people can have excessive sleep. And also the problem with depression is that everything else seems worse. Okay. Causes, hard to know. One of the ways that we try to look at them is there is a deficiency or an imbalance in norepinephrine and in serotonin. So we have a series of drugs called selective serotonin reuptake inhibitors. Remember, excess of serotonin and norepi are associated with depression. And so that's an excess in the cells, in the neurons. And so what we do is when a neurotransmitter leaves one axon and heads, or one neuron and goes to the next, it's then absorbed by the next neuron. So if we can prevent that absorption, this is the theory, we can change depression. By what mechanism, we don't know, but we can change depression. The other is norepi. So we also have norepinephrine, selective norepinephrine reuptake inhibitors, and norepinephrine serotonin reuptake inhibitors. So we have a wide variety of approaches we use for depression, and it happens at the neurotransmitter level of the cell. Lots and lots of drugs. We have a series of we call the tricyclic antidepressants, things like amitriptyline, nortriptyline, doxepine, etc. These will have been used extensively. They have their problems. They tend to be addictive. Also, things like amitriptyline will impair the ability to drive. So you can be arrested for taking your amitriptyline if you drive, because you will drive like you are intoxicated. The selective serotonin reuptake inhibitors are the Prozac, Celexa, etc., Paxil, Zoloft. They work, or they seem to. There's some controversy about whether or not they do. A publication a few years ago said that 80% of the effective SSRIs was placebo. And I guess the response to that is, so what? If the patient gets better or thinks they get better, it doesn't much matter. But there's a lot of controversy at the moment. Okay, we have some selective norepi, Cymbalta and Effexor are useful, and they are blocked to block the reuptake of norepi and thereby modify the disease. And I mentioned before the monoamine oxidase inhibitors. These have now become last line therapy, the last resort when everything else fails. They have multiple side effects, but unfortunately affect an awful lot of the neurotransmitters. And so we don't like to use them if we can avoid it. There are quite a few of those. Well, the problem is dependence on these things is not a physical dependence, but more of a psychological dependence. You think you need the drug to get along, and so you continue to take it. And if my view is that if that's being effective, then that's okay. But you need to be careful that it's actually, that you're actually getting a benefit. Let's see. We take an enormous amount of these things. Most of them now, almost all antidepressants now have a black box warning. Black box warning is a caution to prescribers to be careful to watch out for certain side effects. And the reason is that in some populations, quite often children and young and adolescents, there will be a significant increase in suicidal thoughts. And there have been quite a good number of patients taking these antidepressant drugs who have committed suicide. So thinking, committing suicide when you're taking an antidepressant drug seems kind of counterintuitive, but it does. It really does point out to me that none of these drugs should ever be prescribed to a patient with depression without concomitant psychological counseling. And that should be first line, and the drug should be second line, but counseling should be a part of the regimen for everyone who takes these drugs. because the side effects are so severe.
That's usually when it comes out.
Yeah.
Would you say it's when they reach their half-life, right?
Yeah, usually they're feeling pretty good when they take the drug. So when they start to come down, but these have long half-lives too, these drugs. So why people have suicidal thoughts, I don't think anybody knows it. I think it just enhances that thought pattern. We train ourselves to think or not think. And sometimes it's so severe that they can't function. Let's run quickly to bipolar. Bipolar used to be called manic depression. So they go between stages of being depressed to stages of being very happy and high. We have various drugs that we use to try and reduce the lows and reduce the highs. So to sort of bring people into the middle. If you've ever been around a person who is bipolar, there will be times when they are the funniest and the most fun people to be with on the planet. And then they'll turn around and very shortly thereafter be in a very depressed stage and just you can't possibly understand what's going on inside their head. One of the biggest issues with bipolar patients is they don't take their drugs because even though they hate the lows, they love the highs. So if they love the highs more than they hate the lows, they don't take their drugs.
And you're not. You can refuse.
Yeah, you can refuse. There's nothing we can do. You can't force anyone to take a drug. But what it boils down to, though, is that you're not actually helping them if they're refusing, if they're not being compliant. Compliance is a major issue in these things. The manic phase and the depressive phase can be what we call either long period or short period. You can have someone who's manic for weeks and then depressed for weeks. So the highs and lows go on. Or, and I've seen this, it can switch in 5 minutes. And there's no way to know when it's going to happen. Treatment, we use a variety of drugs. We really want psychotherapy as well. And they use antidepressants. They use what they call mood stabilizing drugs. These are drugs like lithium, which we have no idea how it works. It's been being used, however, been approved since the 70s and used for a lot longer than that. We use some anticonvulsant medications can be used to also stabilize mood. We have drugs for treating psychoses as well. Many of these are used along with other medications. Patients that are on antidepressant therapy or bipolar therapy are often given another drug to enhance the activity. And we use them for, the problem with anything that's active in the CNS is we don't necessarily know what it's going to treat in every patient. So a lot of times we use antidepressants in bipolar disorder, but we need to have those as part of a package of drugs. They need to take an antidepressant and a mood stabilizer so that they can, because if they suddenly stop taking the antidepressant, they can switch to extreme mania, and then they do crazy things. Schizophrenia is also known as psychosis, and schizophrenia is an odd disease. It can be characterized by withdrawal. Schizophrenia is sometimes seen in highly intelligent people, and all of a sudden they just withdraw from the world. They don't lose their intelligence or anything else, but they become incapable of functioning within society. Anxieties, such as OCD or PTSD, panic, social phobias, what we call generalized anxiety disorder. We can treat with some antidepressants, also anti-anxiety medications like the benzodiazepines are used. The other drugs to treat this can be used. The benzos are drugs that build up a tolerance, and so people become dependent on them. We can also use other drugs to help with physical symptoms that come with being with anxiety, such as using beta blockers. The sedatives and hypnotics that we use for people with anxiety is to help them sleep and thereby cut some of the excess activity in the CNS. Usually, anxiety is associated with elevated CNS activity. So we use several drugs for treating that. ADHD, I think you're going to talk about that, aren't you, Cheyenne? Yeah. So, oh, you're doing Alzheimer's. Okay. So maybe somebody in the other class is doing ADHD. Nasty drugs. I advise you, if you haven't seen it, to look up PBS Frontline Special, The Medicated Child. They talk a lot about the drugs used to treat ADHD. ADHD, I think, is one of the most overdiagnosed conditions that we have for children. The big mistake is allowing school teachers to effectively diagnose a child as having ADHD. I'm sorry, they're not qualified, but I blame the school system on that. But the drugs themselves are all Schedule II controlled substances. They're amphetamines, they're the phenidates. They're really nasty drugs with lots of side effects. These drugs work by stimulating the CNS. And, a kid that truly has ADHD can't focus on anything. We give them a drug to stimulate their CNS, they are suddenly able to focus. So they do help some patients. Okay. All right, I'm going to quit there with this slideshow. And what I want to do now is give you guys the rest of the class about a half an hour to start working on the zombie project as a team. Okay. So. The drug class?
It's in right on top. I see the choices, yeah, I don't remember what
Well, right above that should be the description.
Yeah, he gave us.
It is. It should be right above the list. The description should be the next item above the list. Okay, well, let's take a look at it.